In the intricate mosaic of healthcare, it's crucial to recognize the multifaceted journey that an average ESKD patient undertakes. This slide shows you a patient navigating a complex web of end-stage kidney disease care, engaging with multiple providers and healthcare entities. Each encounter, each interaction is a piece of their healthcare puzzle. Unfortunately, the data is often siloed. That means we do a lot of the same things 2 times, 3 times, not out of medical necessity, but out of medical uncertainty. Of course, this complicated landscape is not unique to the ESKD patient. It could really apply to any person struggling with a chronic disease or serious illness. And this is where health information exchanges come in. It's all about trying to put together fragmented information in healthcare to make healthcare better. And as caregivers, you have the unique opportunity to be the architects of seamless patient-centered care, ensuring that every piece of the puzzle fits snugly to create a holistic healthcare portrait that uplifts and supports these individuals on their difficult journey. So we want information to follow the patient. When a patient walks into your clinic, from the moment they walk in, you want to know some key information. For example, who's managing their anticoagulation, their heart disease or diabetes? Where are they with the vein mapping? Are they receiving mental health support? All of these pieces of information you would like to know about them, and these providers would like you to know about it. And that is essentially the role of the health information exchanges. This data is somewhere and you will have access to it. Now you will hear the term health information exchange, or HIE for short, as a noun and also as a verb. And now that can be a little bit confusing, but let me explain. Health information exchange as a verb is the action of exchanging patients' medical information among unaffiliated healthcare professionals. But the entities that provide the infrastructure for secure data sharing are also called the health information exchanges. So you may hear the word HIE to describe both situations, and they're both correct. You will just have to kind of pay attention to the context within the conversation. The health information exchange organizations serve as conduits for seamless flow of patient data. So here is how it works. After a patient's health visit, a healthcare provider documents pertinent details of that visit in their electronic health record or EHR system. The HIE organization then safeguards the access to this information, ensuring that only the participating member providers can securely retrieve the data as needed for continued patient care. The data sharing through the HIE can be inbound, where you receive incoming data from other providers, or only outbound. You only send patient information out to other providers. Or bidirectional, which is really the ideal situation. So this all depends on the HIE services your organization selects. And once a care provider completes their documentation, this information is available in the HIE near real time. That means within minutes. As a clinician, you may be able to access incoming data either seamlessly within your own electronic health record systems, or you may have to go out to an HIE web portal to retrieve or look up patient information. This also depends on the type of integration your organization has allowed. Of course, it's important to underscore that patients retain the autonomy to opt out of electronic health information sharing, thus placing the control firmly within their hands. As you can imagine, having access to the HIEs enables much easier and faster sharing of health information electronically, but there are additional benefits to health information exchanges besides the workflow efficiency. In a world that is increasingly putting cost and other regulatory pressures on doctors and nurses, if we can gather information that helps our clinicians do a better job and helps them to be comfortable so that they're not making any errors or missing critical information, then you can start extrapolating how exchanging health information and aggregating it from various resources can help in better decision making and improve patient safety and outcomes. Electronic health data exchange also facilitates better care coordination. It reduces the odds of hospitalizations and readmissions. And visibility to all labs and procedures from different providers reduces the instances of unnecessary duplicative testing and drives down the cost of care. There are many studies that show us that HIE is beneficial in the ways that I have just described. A 6-month study published in the Applied Journal of Clinical Informatics described 30% lower hospital admissions when staff utilized a health information exchange. A 2023 study in the Annals of Family Medicine found a 61% decrease in readmissions and 53% decrease in emergency room visits following HIE implementation. And 2 separate systematic reviews were conducted in 2018. One demonstrated duplication of procedures, while the other showed us increase in quality outcomes and cost reduction. The benefits of HIE are plenty evident in the literature, but the journey into interoperability is taking much longer than anticipated. Over the next few minutes, we'll go back in time and trace the remarkable evolution of the health information exchanges from their humble beginnings in the 1990s to the dynamic present-day landscape. Before the term HIE was even coined, the importance of sharing health information had already been acknowledged within the community. In 1990, the Hartford Foundation offered grants to 7 states for establishing community health management information systems. These systems acted as centralized data banks of patient health information, where local entities, researchers, and payers could access for various purposes. Another function of this data repository was to streamline billing and patient eligibility in order to reduce costs. Now remember, this was the time, 1990s, before the high-speed internet. Therefore, the process demanded substantial investments in hardware maintenance. Furthermore, there were concerns regarding privacy and potential misuse of this information. For example, physicians in Iowa successfully lobbied against the formation of such data repository due to privacy concerns. And once the grant funding stopped, the operational costs were just too great to sustain, so they all failed. Using the lessons learned from these experiences, the concept of community health information networks emerged. And these health information networks were just the opposite. There was not a central repository. Instead, they opted for a transaction-based approach, where individual providers engaged in information exchange but kept their own data. Sadly, they met the similar fate, because many providers hesitated to share data, fearing competition. And this is the point where federal government steps in with a series of laws, issues, and legislations. It all began with President Bush's executive order in 2004, which he described a nationwide interoperable health information network, and the Office of the National Coordinator for Health Information Technology, or ONC, was created. So however, back then, this is again 2004, most of the providers were still using paper charts, which significantly hindered interoperability. So one after another, 2 important pieces of legislation were passed. The first one was the HITECH Act, passed in 2009, It earmarked significant amount of funds for the nation's IT infrastructure and offered grants and various incentives to the states for developing regional health information exchanges.